Good morning, everyone. Thank you for the warm introduction. Thank you to Arun, Jom, and the rest of the gang for organizing this. It's great to be here with Purushothaman sir, my teacher. The topic that I'll be presenting today is fever in the ICU. So the problem with fever in the ICU is that as the patient's complexity level increases and the presence of the consultants increases, there's often a lot of confusion. There is a lot of complexity and there's a lot of controversy. And this is increasingly more common in our ICUs today with the type of patients we see, with the type of resistance patterns which we see and the comorbidities that we are seeing. So reconciling those is a challenge not just for the treating intensivist, but also for the other consultants, including infectious disease and microbiology. So we'll talk a little bit about that. Next slide. But what I would like to focus on is that you can bundle it into two pieces. One, what is published in the Western literature, what is pretty classically taught as to the common causes of fever in the ICU, which are related to infectious and non-infectious causes. Then we can break away into what is relevant to the Indian context in the setting of tropical diseases that can confound various things that we see in the ICU, especially like the case Dr. Rajesh just shared, is very common in the ICU where a traditional cause of fever in the ICU may overlap with a tropical cause. And that can confound the picture very often. And the third thing that I would like to talk about is more about what not to do. Because in this era where there are a lot of things you can do, it actually takes a team to come back, revisit the patient, and make a list of things that you should not do for the patient. And sometimes that's a lot easier when faced with this complexity. So a very straightforward way to look at it is first look at all the hardware that is there in the patient, whether it is hardware that you placed in that hospital stay, which could be various pieces of plastic, ET tube, Foley's catheter, indwelling lines, or the hardware that was placed in the operating theater, which may be orthopedic or otherwise. That's usually one bucket in which you can analyze different causes of fever in the ICU from an infectious standpoint. The other one are the non-infectious one, and it's an exhaustive list. Typically going down that list happens when a patient has been in the ICU for, let's say, 3 to 7 days. And like I said, you're going back to reevaluate and revisit the causes. This is a common theme in the ICU. Every 2 or 3 days, you need to go back and revisit the causes, de-escalate the antibiotic selection, and see if you need to analyze any other hidden cause that may be there. Next slide. So we'll address the 4 common ones before going on to the other parts of the topic. There are multiple definitions of these sets. And oftentimes, even for exam purposes, we would ask our students, what is the definition of, let's say, a VAP? Ventilator-associated pneumonia, or what's the definition of CLABC? We must remember that these definitions were formulated by the CDC and any other organization that actually is trying to define them for research purposes. And oftentimes, the research definition is either highly impractical to deploy at the bedside, or it may not be relevant to your population. The better thing to understand here is the concept behind these diseases and the fact that they exist as causes. I'll give you an example. CLABC is a CDC definition. CRBSI is a microbiological and a clinical definition. In CRBSI, the definition includes getting cultures from every port of a multi-lumen catheter. Some of them do recommend tip cultures. Some of them say that it is so specific and you have to do it in a certain way that in most labs it may not be relevant. The point is that if you are trying to follow the CRBSI definition in your ICU, you're going to likely order 5 sets of cultures for a patient with 1 central line and 1 peripheral line. There is a cost associated to it. And hopefully there will be newer methodologies to help you with this format, but I'm trying to not let perfection be the enemy of good. The point is that if you go for perfection to meet all your clear definition criteria, you may actually give up some of the good things that these guidelines are trying to message, which is keep your options open in these conditions because they often lead to prolonged ICU length of stay. Especially things like VAP. You can have a patient that was on the ventilator for 3 days because the definition for VAP is any patient who's been on mechanical ventilation for more than 48 hours, then develops a fever. You should still know what sort of organisms that you'll be dealing with for your empirical coverage. And I think that is where the value of these definitions lie, where you can decide empirical coverage, possible duration of therapy, looking at source control strategies. So in our internal review of our network ICUs, the average hand hygiene compliance in doctors and nurses was less than 20%. So you can make up any antibiotic policy and stick to any definition, but if your first line of defense, which is hand hygiene and glove use, for example, is weak, none of this matters actually. The other thing is Foley use in our network ICUs averages between 46 to about 90%, which is a very high use of catheters in patients. And for every additional day of Foley's catheter use, the increase in risk of CAUTIs is about 3 to 7% per day. So the reason why I'm saying this is not to drill down the definition. Each of these has clear CDC defined criteria. The point here is to see how we can adopt this into our practice, either from a bundle-led approach or from a teamwork approach that allows you to reduce the risk of these things. Next slide. So, like I was saying, some of this theme that you'll commonly see is to actually decide when not to treat. And I get these questions from both colleagues and practicing consultants, is that we would see candida very frequently in the urine. And each of these slides is a individual 30-minute topic on its own. So I'm just trying to go as an overview. Frequently, your candidemia or candiduria does not need to be treated. And you are looking for other clues. Is there any existing sign of infection? Is there pyuria that you can help to decide whether you should treat this patient or not? Additionally, these rules may not even apply to immunocompromised patients because they have a separate set of risk factors. They have separate pathogens that can affect them. And depending on how many weeks have passed since they are in the ICU, the profile changes. So for example, in the infectious disease spectrum, you look at the escape organism. So you have escape stands for E. coli, Klebsiella, Enterococcus, Acinetobacter, Pseudomonas, and Staph. And that entire list can get more active in later infections in the ICU. So I think it again helps you in deciding what treatment to use. There is a reason where you should treat, and like I was saying, immunocompromised, if they have a hardware in place, that should increase your index of suspicion to treat patients with candiduria. Next slide. Now, this is also common. We get a lot of questions about if there's a tracheal culture that is positive, should you treat it with an antibiotic or not? And this is a challenge in any ICU, including our ICU. And what we do is we try a multimodal approach, and that's what's recommended. See if the patient has clinical signs and symptoms consistent with a pneumonia. There are scoring systems as well. There's a pneumonia severity index, and these can help you. But the basic idea is there a change in gas exchange, new or purulent sputum, signs of an infection, and a new radiological abnormality? If you have these, then you can think that it's a ventilator-associated pneumonia. You can use biomarkers as well, and that is an area of controversy. Some people would recommend using either a CRP or procalcitonin, but depending on the ICU, the sensitivity and specificity can be quite low. So bottom line is you're never going to get a perfect answer. For example, just to confuse things further, you can have signs of infection, no change in FiO2 requirements, no radiological abnormality, but it can still be ventilator-associated tracheobronchitis. So I think you just have to train yourself to go through that process pretty much every 1 or 2 days in your intubated patient or a patient who is in the ICU with indwelling plastic, whether it's vascular catheters or otherwise. You will frequently have to liaison with your microbiology lab because you want to make sure that contaminants such as diphtheroids or coagulase-negative staph are not affecting your treatment decisions. I was just sharing a culture report with Dr. Purushothaman that we are seeing multiple gram-negative and gram-positive resistance even in Tier 2 and Tier 3 parts of the country. So this is not a Tier 1 problem. It's not a metro city problem. The flow of antibiotics has reached a point where even your first patient coming in from the periphery is likely to harbor drug-resistant bacteria. So the one that I was sharing was a pan-resistant MRSA, resistant to linezolid, vancomycin, even second and third line agents where we have to contemplate, should we be using, say, rifampicin with ceftaroline in this patient, which is a really complex problem. And this patient is a 22-year-old male in a Tier 3 city in India or a village in India. Next slide. Then to combine this, there is a little bit of complexity because you add it to tropical infections. And I'll very briefly cover this because a lot of you here are already experts in this. And just want to highlight that this happens a lot. We have a patient who's admitted with dengue. Next slide. Would be admitted with dengue and will develop an MRSA after the admission is started. So you will have to address both these problems. They may, so for example, applying a syndromic approach which was published in IJCCM, you will find that in pockets where your ICU is active, so for example, we have an area in Warangal and in Telangana where you may have eschar-based diseases like scrub typhus. That scrub typhus will be associated with a VAT. So your antibiotic complexity for that patient is going to increase because you have a tropical infection that you have to address. And the other things that are associated with a tropical infection, like thrombocytopenia, for example, which is very common, can affect your antibiotic choices. Because as we know, meropenem and linezolid can reduce the platelet count. And when faced with a tropical infection, that can confound your antibiotic choices. So I don't think there will be one textbook chapter or one talk that's going to help here. I think what is going to be important in the ICU is to realize that it's always going to be a trade-off. And the trade-off is with respect to a risk-benefit ratio. What is immediately killing the patient is the most important thing to address for the intensivist at that point in time. So if you know that there is thrombocytopenia, but you know there is an MRSA, and that MRSA is in a location that is causing septic shock, I think you'll have to bite the bullet and start vancomycin or linezolid, knowing well that thrombocytopenia is there in the background. So some of these hard calls and trade-offs are more relevant in the ICU because you don't have that much time. Next slide. And the time factor is related to whether it's the golden hour of the antibiotic or the coverage. But the point is that very few things improve mortality in an infected patient in the ICU. And the right antibiotic and source control are probably the two most important. We use a simplified approach because, like I shared with you, there may be a lot of causes. And every year you will deal with some new endemic or some new pandemic that is coming. So that exhaustive list is not frequently useful. So we just apply the Pareto principle. Pareto principle is make a bundle or a format that covers 80% of your problems, and 20% will always require additional research and thinking. So this tends to cover 80% of what we are dealing with. Even empiric cover for malaria in some areas, so where we are active in Bihar and Jharkhand, where we have a lot of Kala Azar and a lot of malaria, we tend to empirically start the patient on artesunate-based therapy because some of the lab work there is not very reliable. Because of that, we may not be able to wait for QBC or the entire information to come back. And oftentimes the smear results are just bogus. And as you may know, the sensitivity and specificity of the antigen-based test, the CARD test, is also not very high, which means that empirical therapy is likely to be the one that you will use in some of these areas very frequently. Next slide. Now, I think we covered this. Some of the things that are important is that in the eastern UP, northern Bihar belt, there is an area where JE is pretty common. And we do see both in the pediatric spectrum overlapping into the young and adult spectrum that delaying the LP has been a problem in some of these areas. So in these ICUs, we typically push for getting an early test done and sending the samples for JE and HSV. HSV is at least treatable, so we would empirically start them on acyclovir. Just a special note on typhoid. The Vidal test is not just a clinical problem, it is also a social problem. The reason why I say social problem is many of these areas are not served by MBBS doctors. So typically they would just do a Vidal test as a typhoid test because they're just trying to make it look as a complete workup. It's done for cough, cold, abdominal pain, diarrhea. Even cellulitis cases are being tested with Vidal, which obviously is not relevant at all. It's a test that's more than a few decades old and frankly has no clinical significance in an endemic country like India. The only use of Vidal is if you get paired sera and you're checking a change in the titers after 2 to 4 weeks, which none of us are routinely practicing. So for an informed clinician, if you want to diagnose typhoid, culture is the gold standard. Vidal essentially can be relegated to the dustbin of history because it actually has no real clinical value. But we see it a lot, and it changes and confuses our antibiotic selection quite often. Next slide. We can skip this. Next slide, please. So when we come to antibiotics and cultures, I'll share a few pointers and then leave it to the hall for maybe a panel discussion. Next slide. Next slide. We have seen cultures in a lot of our ICUs done in very different ways. Next slide, please. And the confusion arises from non-standardization of how they are using their breakpoints, how the microbiology lab is being run, and how they are collecting their samples. That's a completely separate topic, and I'm not going to enter that, but the point that I was trying to say is that very frequently, even in small ICUs where cost is a constraint, I get the question that, doctor, it's expensive to do a culture. So we did a cost analysis on some of these ICUs. We actually looked at their meropenem and piptaz usage. For a patient that has been started on meropenem, oftentimes if you use the culture as a de-escalation strategy, the patient ends up saving money. Because then they are not on meropenem for 5 days, 7 days, or 10 days. You can cut that short. So the point is, when we are working with our partner hospitals and our colleagues, we tell them that use the culture if your goal is to save money for the patient, which it oftentimes is. They're not trying to use meropenem to increase the load on their pharmacy. That's not the intention. But when we make a coherent statement saying we will use cultures to actually reduce the exposure to the antibiotic, it makes sense. So I think while it is the right thing to do, it is a textbook approach to treating infections. We have seen a cost advantage and a practical view of looking at cultures in some of these sites. This is self-evident. It should be done as soon as possible and at the onset, but don't delay antibiotic use waiting for culture reports. Next slide. Now, let's come to the last part of the talk, which is looking at inappropriate use, and this is very common. Some antibiotics don't concentrate in your target site of interest, so polymyxin shouldn't be used in a UTI, for example. The other example that we get is with tigecycline. Tigecycline redistributes in the fatty tissues. The blood levels that it attains is oftentimes very low. There have been at least 2 studies and multiple meta-analyses looking at tigecycline outcomes in bacteremic sepsis, and it has found to be inferior as compared to other therapies. Tigecycline was initially approved for community-acquired pneumonia and septic shock and sepsis. However, the outcomes in subsequent studies haven't matched up. So be careful when you're using this agent for sepsis patients. Nitrofurantoin is okay in outpatient UTIs, but really not a useful drug in the inpatient setting. The other one is metronidazole, and it is rampantly overutilized, especially in many surgical ICUs. We've done a study on this where we found that the number of inappropriate uses of metronidazole is probably very high in the country. And I'll share more examples. Next slide. On your right side, antibiotics when not indicated is actually pretty common. Far more common than the problem that I see on the left side sometimes, where we start the antibiotic but we forget or we are not paying attention to de-escalate it. I think that is an important requirement. The other thing is renal correction of antibiotics is not required for the first dose, and some would say even for the second dose, because if the patient comes with an AKI, let's say the patient comes with a creatinine of 3 with no urine output and has a history of gram-negative infection with an MDR, and you have decided to give them meropenem. The recommendation is to give them a full dose. If you're treating meningitis, give 2 grams every 8 hours. You can always correct the dose after the first 24 hours because you want to hit hard and hit fast. Give the full dose early on. Next slide. This is, I would say, has a 90% prevalence in our ICUs. A common example is that in intra-abdominal infections, after surgery, you will frequently see piperacillin tazobactam and metronidazole. There is no role for this combination. You need to add metronidazole only if you're covering Clostridioides difficile or you're worried about amoebiasis. But on its own, if you have a beta-lactamase combination or if you're using a carbapenem, you do not need to give metronidazole. Frequently overused irrational combination. There are multiple other such combinations. Dual MRSA coverage is not indicated. Frequently, double gram-negative coverage with an aminoglycoside is not always indicated. There are some studies that would indicate that in severe pseudomonal infections, you can think about it as empiric coverage till you have culture data. But we see this being used quite a lot in our patient population. Next slide. This is a very persistent myth. And there is good data that bactericidal versus static discussion should not guide or govern your therapy. This term is an in vitro term. It's a term born out of the fact that as they were deciding the breakpoints, you will see that some drugs are static versus CIDL. In fact, for MRSA, ciprofloxacin doesn't work. But if you give it at a very high concentration, let's say like eye drops, it will actually kill the bacteria at that concentration. So the point is that static versus CIDL is an in vitro term, and it does not translate to in vivo therapeutics. So your decision making should be dependent on whether they are sensitive, whether they are dosed correctly, and if they're in the right organ tissue where the penetration of the drug is appropriate. CIDL versus static is a microbiological term that oftentimes has no clinical relevance. So don't let it govern your choice is the point I'm trying to make. If you have a sensitive drug, use it. Next slide. The other thing is that try to use a beta-lactam as the cornerstone of your therapy. Of course, if it's resistant, we will change the options. But the killing power and the spectrum of activity of these drugs, even today, makes them very useful as a cornerstone of your therapy, even in combination roles. De-escalation is something that I talked about. The other major controversial thing that we see in the ICU is that people talk about prophylactic antibiotics. So there are studies on selective oral and selective gut decontamination for reducing the rates of infections in the ICU. But these were done in Western ICUs. I think if we apply them to the Indian setting, it's a slippery slope. We may actually have more problems than solutions. So as of now, it's not recommended. And preoperative antibiotics are oftentimes continued more than 2 days, more than 3 days, leading to a higher exposure. We published some of this data, and it is again a very prevalent problem. Next slide. This is something that again is from Western data, but we are unfortunately seeing drug-resistant cultures coming from patients who have none of these risk factors. None of these risk factors were there in patients, and yet we are seeing that they have MDR organisms. So while this data is published from the CDC or up to date, the problem is that in India, because of rampant abuse of antibiotics, we are seeing this even without risk factors. So whether it's diabetes, hemodialysis, nursing home residents, we are seeing this from the community. Ciprofloxacin quinolone resistance, for example, in the community, in some communities, is higher than 60 and 70%. Next slide. The other problem that we are seeing, especially when treating fever in the ICU, is how aminoglycosides are being used. The recommendation is to go for single dose daily therapy rather than multiple doses per day. This is something that we would recommend is more commonplace. Resistance to quinolones, as we said. And the other problem is that, again, using Western guidelines to, say, for example, use linezolid in some of our infections may not be entirely practical in India because it is a TB drug. And you want to reserve some of these drugs for patients that may need them. So again, empiric fever in the ICU, we are recommending not to use linezolid even if they have MRSA risk factors because it is a second-line TB drug. So reserving some of these drugs in the Indian setting is critically important. Next slide. So to conclude, I think the most important part of fever in the ICU is to realize that there are infectious and non-infectious causes. There are a lot of treatment modalities that are available to us, and oftentimes in the ICU, just looking at paracetamol to curb the fever is not a wise strategy, as is evident from the talk, because there are so many other causes, whether it is ischiorectal abscess or acalculous cholecystitis. But one thing to note is that controlling the fever has never been shown to change mortality. Perhaps in CNS conditions where a raised ICP is related to hypothermia, you can use paracetamol or surface cooling to reduce the temperature. But other than that, for infectious causes of fever, especially when the patient is intubated, treating the fever itself has no mortality benefit. Maybe a comfort benefit, But other than that, focusing on that is probably not important. I think you should leave no stone unturned to find the cause, because in the ICU, as we've discussed, the causes are complex and oftentimes difficult to unearth. Removing catheters is another thing that is important and gets forgotten. So for example, if you have a center line that's in place for more than 5 to 7 days, that should be a focus of your interest to look at it as a cause and even remove it. There are a lot of things to discuss about CLABSIs and what to do with a center line. Just briefly, if the line can be removed and replaced, that is a recommended strategy. Let's say in onco patients where you have a central line that's indwelling and you need it for chemotherapy, you can institute things like lock therapy, where you can instill the catheter with an antibiotic to just buy yourself time. And then I think the most common thing right now that we are finding for fever in the ICU is actually the over-treatment part. So as intensivists and people running ICUs, it's probably important to look at the over-treatment. It's very unusual for you to find cases where you're under-treating a patient in today's day and age. Somebody would consult someone, the patient would be on Aztreonam and ceftazidime, avibactam before you realize it. So I think as a clinician, the decision-making is more going to be, what are the drugs that I can cut off? What are the treatments that I can stop, rather than starting? Because the barrier to start actually is very low. So that was a point that I would like to conclude on. Thanks for the hearing, and if there are any questions, we'll move them to the panel.
So summarizing, this is a 14-year-old healthy young male with a history of travel. As my professor Purushottam used to say in the past, tropical infections is always a epidemiological, clinical, basic and lab diagnosis mediated diagnosis. So in this case, we considered the possibility of a tropical infection, and he had fever more than 1 week. So we ruled out the possibility of viral. So we were left with enteric, malaria, scrub and vocal sepsis. So based on that, we evaluated malaria negative, dengue negative, and scrub was also negative. So what is the most likely diagnosis? Based upon fever, this boy had a multiple system localization. So we have multiple system localization. One of the differential diagnosis should be tropical infections, even in an ICU, as Dileep pointed. So we proceeded with cultures, and in our hospital, we do IDAL, because we correlate with the clinical setting. So there is a difference of opinion. So clinical diagnosis was enteric. So blood culture and sensitivity showed Salmonella typhi. Rest of the investigations were negative. So when you study the course of enteric, actually it was a bit different. Patient had a very significantly low platelet and very falling platelet count also. Thrombocytopenia is not very commonly seen in enteric, and high-grade fever is not. So if your disease is not following its own course, there should be a superadded complication, and one of the complications suspected was HLH. So the slide was only to highlight to consider the possibility of HLH in most of the tropical infections, particularly if you know the cause of the disease and if it is not following the proper course, with a falling counts, falling ESR, multiple organ damage, and with immense mortality. So, and he had bone marrow showed plasmacytosis. So that was a case of enteric with secondary HLH. Here we need to give steroids. So we gave steroids only his fever subsided. So usually enteric, so that is the point. So the slide was to highlight the importance of considering secondary HLH as a part of almost infections in our community. Thank you very much. Next. So we'll open with the second question and I will move back. This is the case, Vietnamese time bomb. So next slide. Next slide. This was a 39-year-old male who was a type 1 diabetic. He was a chronic alcoholic. He presented to us with fever of 1 month duration, weight loss and cough. He was later, 1 week later, and in 1 week prior to admission, he was brought in shock, and he had clinically he had left upper lobe consolidation. He was admitted in pulmonology. Because 1 month fever, he was evaluated for tuberculosis, and he came with sputum AFib results negative, and fever was persisting. Next slide. So this was the CT report. There was a possible early pulmonary necrosis, possibility of tuberculosis to be ruled out, and possibility of lymphoma to be considered. And with this, he was referred. Next slide. So investigation showed leukocytosis, polymorphonuclear leukocytosis, ESR above 100, and his RBS was uncontrolled, creatinine was impaired, alkaline phosphatase was on the higher side, AFB negative, CBNAT negative, HIV negative, and he had a sputum culture which showed Klebsiella, and was based on that he was started on Piptas, and the fever was persisting. So this is the case scenario given. So what are the possibilities to be considered, or what is the most likely diagnosis in this case based upon the clinical symptoms, clinical signs, and the comorbidities associated with the patient?